Thanks very much, Emma. I appreciate that. Welcome, everyone. So, got a lot to get through here today, the day before Thanksgiving. So, we're gonna jump right into this. So, we're talking about the evaluation of a peripheral blood smear, and we're specifically gonna delve into what a blood smear can tell us above and beyond the automated hematology analyzer results. And ideally, this is to enhance clinical decision making. So today, what we'll specifically discuss are the automated hematology analyzer results, what that info is and isn't conveyed, and then how to evaluate a blood smear in 5 minutes or less. And with experience, I think you can actually get it down to 3 minutes. And I do want to point out for this cartoon that that's not a real blood smear. There are red blood cells that sometimes are referred to as donut cells, but I think these are completely different than what we're talking about for clinical pathology. So we'll take a look at red blood cell parameters from the hematology analyzer, as well as evaluating red blood cells, then jump into white blood cells, and finish up with platelet evaluation on the blood smear. Do want to point out that for high resolution oil immersion based digitized images, which these are examples of, it allows you to enhance your blood smear evaluation there, because you can actually zoom beyond what a conventional microscope, 100x. You can use digital zoom to get in a little bit further, as well as the oil immersion improves the resolution. Digital images also allow for rapid treatment decisions, primarily because not only can you get the image into a viewable format, zoom around, and even capture some of those images, but if you need an expert consultation, most laboratories that are providing digital microscopy or consultation services can turn that around within about 2 hours or so. Compare that to if you're sending out a glass slide for a stat consult from a clinical pathologist. Even if you're close to a laboratory, have close proximity to a laboratory, you're still probably looking at 6 hours to maybe 8 hours for a turnaround time on that, and getting a report back. And of course, if that's in the afternoon, then an overnight delivery or courier pickup could extend that out to 24 hours. So as we go through today, I'm trying to do this so that you can make a decision quickly and decide whether you need additional consultation on that. One of the other advantages of digitized images is that you can include that in the medical record. You can use it to follow progress, response to therapy, or lack thereof. And you can also provide images to the client, which may help drive the message home as to what the underlying problem is, and how to follow your therapeutic recommendations. So the automated analyzer results give you a really big picture, but it's really not the whole picture. So we're just going to briefly jump into the red blood cell parameters that are obtained off automated hematology analyzer, and we're talking about ones that are in clinic, not necessarily a reference laboratory type of hematology analyzer. And we're specifically going to talk about, for the red blood cell parameters, we're going to talk about anemia here, and look at parameters associated with anemia, and then what we can do with a blood smear above and beyond that. So if there is anemia, then the majority of the in-house clinical analyzers can provide a reticulocyte count, and that reticulocyte count, depending on whether above the reference interval, can be determined as regenerative count, and if it's within the reference interval, and some intervals actually go all the way down to 0, so hard to be below the reference interval in those cases, then it's certainly a non-regenerative anemia. And this is all pretty straightforward. So reticulocytes on a diff-quick or right-stained smear are actually called polychromatophils. Reticulocytes, to truly identify a reticulocyte on a blood smear or blood film requires new methylene blue stain, and that stain's problematic, so it's not typically used in a clinic situation, but can be used in a reference laboratory. However, with that being said, most of the hematology analyzers that are available in clinic that do perform reticulocyte counts, they're pretty accurate, within a few thousand per microliter there. So not always necessary to evaluate a blood smear to determine if there's a regenerative or non-regenerative response. So quickly here on this this image, the arrows are the long arrows are pointing to the polychromatophils, and this is on a right stain smear. There. So we do have the red cells, and this is a nucleated red blood cell here. It's actually a metaruberocyte associated with that. And then these are the other grayish blue cells that are present here are also polychromatophils. If we stain this with new methylene blue, those would be the reticulocytes. So they're larger cells and have a grayish blue color to them. The arrowhead right here is actually pointing to a Howell Jolly body, which is inclusion on the red cell. And we'll talk specifically about Howell Jolly bodies as we move through the smear evaluation. Some of the in-house or in-clinic hematology analyzers can actually flag for the presence of these nucleated red blood cells, but most of them cannot enumerate the number that are present. So that would require a smear evaluation to get an idea as to how many of those are present. There has been some discussion that for that flag that it may flag it as mild, moderate, or marked there, but ideally a blood smear evaluation is required for that. Other parameters provided by the automated analyzer include the red blood cell size, which is the MCV, as well as the hemoglobin content, MCH, mean cell hemoglobin, and MCHC, mean corpuscular hemoglobin concentration. I tend to put a little bit more weight on the MCHC. However, MCH should follow MCHC and vice versa. But this value tends to be a little bit more accurate, especially with the in-house analyzers. So let's talk about some of the specific changes with these RBC indices. Macrocytosis and hyperchromasia, so an increase in MCV and a decrease in the MCHC. Most commonly, macrocytosis and hyperchromasia is associated with a regenerative response to the anemia, so an increase in reticulocyte counts. And because polychromatophils or reticulocytes are less mature or immature anucleate red blood cells, they tend to be larger and have their full complement of hemoglobin. Because the cell volume is greater than a mature erythrocyte, then the effect is to have a lower hemoglobin concentration per volume of that cell. Associated with that regenerative response, as said, reticulocytosis, and the two big rule outs that were drilled home ad nauseum, especially when I was in vet school, were loss and lysis, hemolysis, hemorrhage, loss and lysis there, or in this case, lysis and loss. Macrocytosis in normal chromasia, so an increase in mean cell volume, but a normal or within the reference interval MCH, MCHC. Most commonly in cats, has been associated with feline leukemia virus infection. There's actually an inhibition of the cell division associated with during erythropoiesis, and so the resulting end stage erythrocyte is larger, but does have its normal hemoglobin content. Poodles, especially toy poodles, but even standard poodles can have larger macrocytic cells or large red blood cells with a normal hemoglobin content. Vitamin B12 or folate deficiency, so these nutrient deficiencies can actually impair the cell division, so they doesn't undergo that final cell division, and as a result, the mature red blood cell or terminal red blood cell during development is actually larger, but still maintains its normal hemoglobin component. And then let's talk about microcytosis and hyperchromasia. So decrease in MCV and decreased MCH, MCHC. And the classic rule out for microcytosis and hypochromasia is iron deficiency, and we'll come to that in just a second. So let me just point out some microcytic cells here with the white arrows. So again, these are the polychromatophils or reticulocytes, nuclear red blood cell. And then these cells here are smaller, not a whole lot smaller, but smaller than some of the other cells that are present. And then in these, this is blood from a dog. The area of central pallor is increased in these cells. This cell here is probably more typical of what you would see in a dog erythrocyte, canine erythrocyte there. So you can see just certainly expansion there. If we were to stain this cell with new methylene blue, I suspect that even though it's not quite as gray blue as that, I suspect that this would actually be a reticulocyte and has a decreased amount of hemoglobin, even given the volume of that cell is increased. So iron deficiency, classic for that. However, more recent research has shown, and with iron deficiency, with that anemia, it used to be classically called non-regenerative anemia. However, depending on what the underlying cause is of that iron deficiency, you may see cyclic regenerative response. So it just depends on where you catch them in that response. So as the bone marrow obtains a sufficient store of iron for heme synthesis, then you may see a mild regenerative response there. But again, the classic is a non-regenerative anemia with that. Copper deficiency. Copper is required by ceruloplasmin, which is a transport enzyme or protein to move iron across the gut epithelium. So copper deficiency actually results in a secondary iron deficiency. Vitamin B6 deficiency results in a microcytosis. Vitamin B6 is required for heme synthesis. So because there's not a full complement of heme, which determines when cell division should end, hemoglobin content reaches its maximum concentration. Because that heme synthesis is impaired, the developing erythrocytes undergo additional cell division, resulting in these microcytic cells. They may or may not be hypochromic with the vitamin B6 deficiency. Chronic external blood loss, so you're actually losing iron to the environment. With internal blood loss, that iron is rapidly recycled, stored, and frequently with internal blood loss, it's a regenerative response associated with the macrocytosis and hypochromasia there. But with the external blood loss, it's in effect iron deficiency. And then finally, normocytic normochromic. Most commonly, when we see normocytic normochromic anemia, it's non-regenerative due to impaired erythropoiesis secondary to inflammatory cytokines, and the anemia is mild with inflammation. And that's actually due to sequestration of iron in bone marrow macrophages, but it does not get to the point, regardless of how severe the inflammation is, the mechanism does not get to the point where you actually get this microcytosis and hypochromasia. There's a normocytic normochromic inflammation, white blood cell count should help confirm that. Chronic renal disease associated with decreased erythropoietin, kind of a classic there for normocytic normochromic. And then endocrine disease, hypothyroidism being the most common cause of normocytic normochromic non-regenerative anemia. Chronic lead toxicosis can also result in a normocytic normochromic anemia. Lead impairs the heme synthesis also, so it's almost always non-regenerative and has been associated with increased numbers of nuclear red blood cells. So you see these in the absence of the polychromatophils or reticulocytes. Excuse me. Just getting over a cold, so perfect timing. So as I said, increased NRBCs without reticulocytes should give you some idea that potentially lead toxicosis is there. I was going to say that when I was in practice years and years ago, I had a cat that had non-regenerative anemia and lots of NRBCs, and I went through all the rule outs and could not find a source for lead until I found out that the cat was licking vinyl blinds that were made in Mexico, and they actually had lead paint on those vinyl blinds. And so once we figured that out, which took several weeks and some supportive therapy, able to restore the hematocrit in that cat. Okay, so back to the automated analyzer results and an increase in absolute reticulocyte count with anemia. So that is a regenerative response. As I mentioned before, automated analyzers, some of the in-clinic analyzers can flag for the presence of NRBCs, but they don't specifically enumerate them. And when we see this pattern here, with the increased reticulocyte count, potentially NRBCs in relatively low numbers, it's part of the regenerative response, then we're looking at hemolysis or hemorrhage, internal hemorrhage, as the most likely mechanism there. But what specific mechanism are we talking about? Can the automated analyzer actually provide an answer? Not really. So it's time for blood smear evaluation. Now, when I was a professor at University of Georgia and teaching the first laboratory to second-year veterinary students for clinical pathology and hematology, this was my unofficial research project. And I think I experienced it too when I was a veterinary student. However, I believe the green proportion for me was probably even less than what's shown here, and the blue portion was greater. So, but with experience, you can not see your eyelashes anymore. All right, so where do we need to evaluate a blood smear? It's got to be the feathered edge and the monolayer, and to find the feathered edge and the monolayer and to truly evaluate that, it requires a well-prepared, well-stained blood smear. So here is actually a really nicely prepared blood smear. The spreader slide was pulled back into the blood droplet about halfway through. The angle on the spreader smear or slide should be around 30 degrees, and push it away all the way to the end, and that at a nice steady speed, it will result in this really nice feathered edge here, a parabola there, and nice straight lateral edges. And then from that feathered edge, this is the red box indicates where the monolayer is. Okay? And that's usually 1.5 to 2, maybe 3 fields back from the edge of that feathered edge, from the distal extent of the feathered edge, should put you in the monolayer. And that's where about 1/3 to 2/3 of the red blood cells will be touching one another. When you go back here, the red cell morphology is distorted. And out here, as are leukocytes, and out here, it's too thin. And I'll show you some images of where it's too thin and what happens to the red cells there. All right, so blood smear evaluation. So this is a image that I took from Cornell's eClinPath. It's actually a really nice image here, and it's I digitally zoomed this also to really try to point this out. But this is a blood smear from a dog. And if we look closely at these cells, dog erythrocytes should have central pallor in them. This is a platelet here. This is just some debris associated with that. So there are a couple of erythrocytes here that have central pallor, but almost all the other erythrocytes present lack that central pallor. They're very round. These are round, and they're smaller. So they're microcytic, small, lack central pallor. These are spherocytes. And when present in moderate to marked numbers, those spherocytes are associated with IMHA. Sometimes with transfusion of stored blood and really stored blood of any duration, spherocytes will start to form in that stored blood. So be aware that if you are transfusing a patient, especially in a patient with IMHA, that potentially will have introduced spherocytes into that patient. And there's really no way to distinguish the number of spherocytes that are patient associated versus transfusion associated there. So it can be difficult to monitor response to therapy when you're using stored blood for transfusion. For transfusion of fresh blood, whole blood transfusions, don't expect to see spherocytes with that. So just be aware of that, a little caveat. When you get out into that feathered edge, when you get really thin there, almost all the red cells, regardless of species, will start to look like spherocytes. So be careful in that you're evaluating for the presence of spherocytes in the monolayer. And again, that's about 1/3 to 2/3 of the red cells are touching one another. And from there, if you're seeing these and you want to see, especially in dogs, that central pallor in the other cells, and to truly call it a spherocyte, it should be smaller and very round there. So this one here could be a spherocyte, but it's being distorted by the red cell next to it. Same thing here. So I wouldn't call those spherocytes. They may be, but I'd feel comfortable certainly calling that one, these here, these smaller, perfectly round cells as spherocytes. So slight to mild numbers of spherocytes at the feathered edge, probably normal, especially if it's in cats, because they lack that true biconcave disc that you see in dogs. All right, moving or keeping with our theme of hemolysis here and the presence of spherocytes, ghost cells may also be present. And some ghost cells, which are present here, and I'm just draw some arrows in here. These are all ghost cells, and there are quite a few more here. And it's actually an erythrocyte. It's still intact, but it's lost its hemoglobin content. So it's just the cellular membrane there. If you notice in this one, all the red cells, they kind of look like spherocytes, but less than 1/3 of the cells are touching one another. So we're in a really thin area of the smear. And additionally, the cells here are staining orange instead of that pink, nice kind of pink red color. And the leukocytes are understained too. This is actually an artifact of too acidic of a wash buffer that was used to wash the stain off. And that can actually cause lysis of the cells and these ghost cell formation. And again, if you're out here in the really thin area of the smear, everything looks like spherocytes. So go into the monolayer and make sure that the spherocytes are truly there. I have never seen ghost cells present without spherocytes. Just can't ever recall that happening. So this one was an artifact, but if they truly were spherocytes, we were in the monolayer and we saw those ghost cells there, and it was a nicely prepared, well-stained smear, then IMHA is still your primary rule out. All right, let's move away from hemolysis associated with IMHA and into oxidative damage, which is just another cause of hemolysis, but not immune mediated. Heinz bodies are the hallmark of oxidative damage. All these arrowheads are pointing to Heinz bodies there, and they are generally on the periphery of the cell. They are stained about the same color as the red blood cell does itself. The white arrows, are free Heinz bodies, so they have ruptured off the red cell. Heinz bodies are actually denatured hemoglobin that precipitated to the cell membrane, and if they are large, they can rupture from the cell membrane. You can see them in the background. If there's lots of Heinz bodies, automated analyzer may actually pick those up as platelets because they're about the size of a platelet, at least in dogs and cats. There's a lot of other Heinz bodies present that I didn't put arrows on. So these are Heinz bodies. That's a Heinz body. And then what I think we're looking at here in these red cells, it's not central pallor. It's actually a Heinz body on the membrane, and we're just looking at it top down there. So those are all Heinz bodies, and I'd consider this a moderate marked case, and they're really large Heinz bodies too. So some of the classic oxidants associated with oxidative damage, Heinz body formation, are onions, garlic, propofol, acetaminophen, Tylenol's a classic, benzocaine. I actually managed to, when I was trying to intubate a cat that was having laryngospasm, and I was using lidocaine, and I kept using more lidocaine in that cat to intubate it, managed to induce a nice Heinz body anemia that was apparent about 2 days later. So ended up having to support that kitty through the Heinz body formation. And because this is denatured hemoglobin, it is not, the Heinz bodies are not reversible compared to met hemoglobin, which is a reversal, can be reversed there. So met hemoglobin, if you recall, is where the the iron redox status goes from 2+ to 3+. Zinc, associated with pennies from minute before 1983, most common. Have seen it associated with battery ingestion there. So belt buckles, shoe buckles, things like that, zinc plated there. So I don't think there are a whole lot of pennies around from 1983 or earlier. And then it's also been reported with diabetes mellitus and primarily DKA, diabetic ketoacidosis in cats, and it thought that the ketones are actually causing oxidative damage there. In a study comparing DKA in cats to cats with uncomplicated diabetes mellitus, the DKA cats had a much higher percentage of Heinz bodies associated with it, and they were anemic too. So just be aware of that possibility. Eccentrocytes. So still under oxidative damage, and the eccentrocytes, also known as blister cells, it actually looks like a blister on the edge of the cell. So these are eccentrocytes there. The blue arrow here is an acanthocyte, and this is a kinocyte, maybe a kinoacanthocyte. But the primary thing to recognize here are these eccentrocytes caused by the same list of oxidants that will cause Heinz bodies. You can see eccentrocytes in the absence of Heinz bodies and vice versa, but you can also see them together. So just keep that in mind when you see that blister type cell. That is oxidative damage. All right, so Howell Jolly bodies versus Heinz bodies. This used to give me and certainly all the veterinary students that taught over the years trouble. So Howell Jolly bodies are nuclear remnants that were not extruded from the red blood cell during maturation, and with accelerated erythropoiesis, with a reticulocytosis, a regenerative response, you can see increased numbers of Howell Jolly bodies present. They're typically dark blue and either in the center or somewhere along the within the red blood cell, but they're not on the periphery compared to those Heinz bodies that we saw before. Notice that again the Heinz bodies stain about the same color as the erythrocyte itself, and so that's one way to differentiate it. Because cats and horses have non-sinusoidal spleens, Howell Jolly bodies typically persist in circulation for much longer than what we would see in dogs. If there is a increase in the number of Howell Jolly bodies, look for the presence of those polychromatophils, or look at the reticulocyte count, because it most often associated with the accelerated erythropoiesis in all species. And then if you splenectomize a dog, it's not uncommon to see increased numbers of Howell Jolly bodies. They're typically not anemic, no reticulocytosis there. So keep that as a consideration also. Okay, rouleau versus agglutination. So this is a digital scan off of the Zomedica TRUVIEW scanner. And you can see all of these red cells are lined up. They're in the direction of the smear was actually made in this direction here, moving from top to bottom there. And so the red cells are all in the same direction. These aren't forming the classic stack of coins that was knocked over, but they're varying in length, but they're still lined up pretty well here. And this is rouleau. That's rouleau, that stack of coins. It is associated most commonly with pathologic causes of rouleau, most commonly associated with inflammation, hyperfibrinogenemia, sometimes with increased antibody production, so IgG, IgM with that. Red blood cells have a net negative charge. It's called the zeta potential, and those are repellent forces, so the red cells should repel one another. But fibrinogen and antibodies are, especially fibrinogen, are positively charged. That reduces that net negative charge on the red cells, so you get this rouleau formation. Compare that to agglutination, and I actually chose this slide, even though the red cells are not sharply demarcated here. This is one of the more impressive views of agglutination, frequently described as grape-like clusters there. And so you can see them throughout the smear. Again, you want to be in the monolayer to evaluate this, because you can get both rouleau and what it looks like agglutination at the feathered edge, or if you go too thick into the body of the smear, then you'll start to see what looks like agglutination there. If you're unsure, and let's see if I can find some. So it looks like maybe there's some potentially some rouleau here. And if we didn't have these big grape-like clusters and we were seeing things like this here, and hopefully everybody's seeing my cursor as I've been talking for 30 minutes now, whether trying to differentiate between rouleau and agglutination, you can actually do a saline dispersion test. And then you start off with 1 drop of saline, 1 drop of blood, put it on a slide. You can just tilt the slide to mix the saline and the blood together, drop a cover slip on it, and look at it under the microscope, scan it for digital images. And if it's rouleau, the saline will disperse this here. It may take up to 5 drops of saline before you get dispersal, especially if there's a marked hyperfibrinogenemia with that. Once you go above 5 drops of saline, then the tonicity changes and you've got a chance of lysing the red cells. So if it hasn't dispersed by application of 5 drops of saline, then it's agglutination. Hopefully there's some other things that you can evaluate for that agglutination to look at the cause of the agglutination there. Other common shape changes. So poikilocytosis, it's really a general term of abnormal red blood cell shape there. Sometimes it's used when the cells really just don't fit into any known category. So yeah, kind of a acanthocyte, but not really, and kind of not really a echinocyte. So I'm just going to call that poikilocytosis there. And this is from a dog. I don't know what the underlying pathology was in this dog to cause that poik, but this is, given the probably 40% or so of the cells, I'd consider that abnormal there, abnormal poikilocytosis. And would have to do some more investigation as to underlying cause. So when you see poikilocytosis in a cat, and specifically acanthocytes in a cat, primary rule out should be hepatic lipidosis. There are other causes, but that's the first thing that I'm going to go for. And certainly check liver enzymes and then consider some imaging modalities for that. Schistocytes. Schistocytes are fragmented red blood cells. This is definitely a fragmented cell. I think this one's also fragmented, kind of between an acanthocyte and a schistocyte there, but not real important that we definitively identify that one. These are target cells here, also known as codicytes. Sometimes this was the donut cell. They're not donuts. There, got some platelets right here, but these schistocytes indicate that there's some kind of red blood cell trauma during circulation, traversing the vasculature, and most commonly that's fibrin deposition. And the combination of schistocytosis, and thrombocytopenia, DIC, primary consideration. Again, DIC is not a primary differential, but consider DIC as that cause of schistocytes and potentially fibrin deposition intravascular with that. Echinocytes. Echinocytes are characterized by multiple, usually short, pointy projections or sharp projections on them. So most of these are echinocytes. There are some of the ones that are touching one another get a little bit distorted. I zoomed in very close on this to try to demonstrate the multiple kind of pointy projections there. Echinocytes, the presence of echinocytes, point out on this one, all of these right here are also multiple projections. We're just looking at them head on. So again, echinocytes without anemia, most commonly it's an artifact of slow smear drying, and that's a particular problem in high humidity environments. So if air conditioning is not working that day and it's summer in Georgia, echinocytes are really common. For pathologic causes, things like electrolyte abnormalities, primarily a sodium imbalance, as well as snake bites, bee stings, spider bites, some kind of envenomation, those can also cause echinocytes. But most commonly, especially without anemia, think slow smear drying, and it's not a pathologic process. And then acanthocytes, which we touched on just a little bit earlier, are characterized usually by 1, 2, sometimes 3 blunt projections. A colleague of mine calls them the Shrek cells, and I think that one kind of looks like Shrek. There, I think my son would probably agree on that. And acanthocytes, when they're present in a dog with hemoabdomen, primary differential, and really until proven otherwise, hemangiosarcoma. So evaluation in the spleen, evaluation in the liver, associated with that. It is really uncommon to see acanthocytes in a dog with hemoabdomen and not have hemangiosarcoma. In fact, I cannot recall the last time I've seen that pattern of acanthocytes and hemoabdomen in the absence of diagnosis of hemangiosarcoma. All right, so let's move away from shape changes and into infectious agents. Really, it requires at least 50x and either some form of digital zoom or if conventional microscope, 100x oil to identify, to even see them, number one, and then to try to further identify them. If you can't capture a digital image using a digital scanner of a suspect's infectious agent, I recommend sending for expert confirmation. And while you're waiting on that turnaround, especially if it's a digital slide, 2-hour turnaround time, you can at least consider formulating a treatment plan and potentially a prognosis as to what your primary rule outs are. So I'm just going to show a few here and try to differentiate them from some other inclusions like Heinz bodies or the halojollic bodies. So this is blood from a cat. These dark inclusions, they're on the membrane. They're not actually in the red cell, so they're attached to the cell membrane. They're often rod-shaped. This is Mycoplasma haemophilus. So they're present on looks like about 20% or so of the cells. Differentiate these from halojollic bodies, which are usually larger. They're about the same color as halojollic bodies, but the halojollic body is going to be in the erythrocyte. Okay. So Mycoplasma haemophilus there. Maybe that's one there, but it just seems wrong color, too light with that, but it could be looking at it top down. Oh, good. I was correct. Sorry. All right. This is blood smear from a dog, and this one, this dog was actually very anemic. This was characteristic of monolayer hematocrit on this. In this dog was around 12%, according to Texas A&M, to my colleague at Texas A&M that provided this there. In this zoomed in box right here, these are the signet ring shape. So that the nucleus right there, the dark orange or reddish color, is the stone, and then the ring portion or the band there. And this is most consistent with Babesia gibsoni. Usually it's seen as one organism, sometimes a pair of organisms together. Babesia canis is often associated with 2 to 4 organisms within the red cells, but probably not real important that you actually are able to speciate it, but at least recognize that, hey, there's some inclusions here, and this red blood cell density is markedly decreased. Automated analyzer much better at detecting and counting red blood cell count. And then here's just kind of a gee whiz. This is Mycoplasma hemolame. This was from a case that I had when I was professor at Virginia Tech. And this was in a 4-day-old cria, alpaca cria. And all of these little blue dots are mycoplasma. So it wasn't a challenging microscopic diagnosis, but what was interesting on this is that this was in utero transmission. So this cria actually had these present at the time of birth, and then this photo was taken at 4 days old. All right, let's move on from red blood cells, and let's jump into white blood cells, white blood cell parameters off of the automated analyzer. They're really good at providing a white blood cell count. Some analyzers do a 3-part differential, others can do a 5-part differential. That 3-part is granulocytes, lymphocytes, and monocytes, and then the 5-part is segmented neutrophils. Some can flag for the presence of immature neutrophils or band neutrophils. Lymphocytes, monocytes, eosinophils, basophils, and then very few in-clinic analyzers can detect what are called LUCs, or large unstained cells, but that is a parameter on reference laboratories. So I did want to include that, but it's rarely included on a in-clinic hematology analyzer. Automated analyzers cannot enumerate immature neutrophils or granulocytes, and only a few of them can even flag for the suspected presence of such granulocytes. So that requires blood smear evaluation if there is a flag for it, and determination of what the population is and how immature are the cells. You've got to look at a blood smear for that. Includes bands, metamyelocytes, myelocytes, even promyelocytes. Those are more commonly seen in the bone marrow there, but these are the 3 big ones that we generally talk about. So I'm just going to show you here. This is blood from a dog. There is rouleau present and potentially some agglutination, kind of forming that little grape-like cluster there. So if we weren't sure, we could do that saline dispersion test. Automated analyzer results should tell us that there's a leukocytosis, but as we can see here, and this is at a 50x magnification, that leukocyte density is increased, red blood cell density decreased there. The primary cell type are segmented neutrophils, but there are band neutrophils present. Band up here, band there, band down here. Bands are characterized by having the nuclear walls parallel for about 2/3 the length of the nucleus. Once you get, we don't have parallel nuclei, then question is it a monocyte, which I believe these are, with the fine and real discrete vacuoles, just a few of them there. Kind of has that horseshoe shape like a band, but not quite. And then another monocyte here with just a couple of little vacuoles, And then this is a metamyelocyte here with that. No vacuoles present, chromatin's a little bit more open, and not a horseshoe or S-shaped or something along those lines. So in this patient, there's immature neutrophils at least to the stage of metamyelocytes. So this would be a neutrophilia with a left shift, and it's an orderly left shift, so the less mature cells are fewer in number as we go back in stages. And I don't know if there were any myelocytes in this patient or not. So there's a specific response called a leukemoid response. It's typically associated with leukocyte counts or total white blood cell counts of greater than 50,000 cells per microliter, and it's an orderly left shift. Leukemoid meaning leukemia-like. It looks like leukemia because there's so many cells, but it's that orderly left shift. With leukemoid response, there's 5 big rule-outs, primary rule-outs, and that's the PIOS, so pyothorax, pyometra, pyoabdomen, endocarditis, and IMHA. And in this patient, this was a leukemoid response secondary to IMHA. There are actually spherocytes present here. So we do see some central pallor, but there are some really nice small round cells that perfectly round, microcytic, lack central pallor, IMHA with a leukemoid response. With the advent of digital images and the use of AI or really deep learning, you can perform an automated 5-part differential much faster than any human can. And not only can you perform that 5-part differential, but you can classify these immature leukocytes and even enumerate them. Additionally, detection of toxic change should be available for deep learning. It's something that we're working on, trying to identify that using deep learning and training some models to identify toxic change in the neutrophils. You can also detect reactive lymphocytes, so immune-stimulated lymphocytes, and even atypical lymphocytes or leukocytes that don't fit into this, into the immature granulocyte category there. Furthermore, and there are some digital scanners with AI deployment on them that can detect the NRBCs and even enumerate them and give a count per either 100 white blood cells or per microliter. So we talked about a neutrophilia with a left shift, the leukemoid response. Now let's talk about a degenerative left shift. And classically, the definition of a degenerative left shift is immature neutrophils greater than the number of segmented neutrophils. Now remember, an automated analyzer cannot detect those immature neutrophils, and especially once you go beyond bands, and it can't enumerate them. So we don't know whether it's a orderly left shift, a degenerative left shift, or some variation in between. For me, to really call it a degenerative left shift, there has to be a neutropenia or at least a normal segmented neutrophil count. Degenerative left shift carries with it a guarded to poor prognosis. So for me to call it degenerative left shift, I want to see that neutropenia normal or a normal segmented count. And that, a degenerative left shift implies that the bone marrow cannot meet the demand for phagocytic cells, for neutrophils. The tissue demand is just so great. Degenerative left shifts often accompanied by toxic change, and we'll talk about that in a minute. Do want to show you this. This is a blood smear from a dog, and the question here is this a degenerative left shift? Are these immature neutrophils? And if they are immature neutrophils, and I think they are in neutrophil series, then, and this is the blow up, increased digital zoom there. This looks like a metamyelocyte, and this is either a late metamyelocyte or early band, depending on definition of 2/3 parallel wall for 2/3 the length of the nucleus. Yeah, I don't know. Looks like leukopenic. There are lots of echinocytes here. I see a polychromatophil reticulocyte there, a couple of platelets scattered around. Don't see too much else going on with the red cells. Degenerative left shift, often accompanied by toxic change. Well, even though we haven't talked about toxic change, I see no evidence for toxic change there. So in this case, it'd be really helpful to know that this is an Australian Shepherd, and this is actually Pelver-Hewitt anomaly there, which is a genetic condition associated with hyposegmentation of the nucleus there. And if we looked around, we would not find any truly segmented neutrophils, mature neutrophils. The chromatin is really condensed. It's mature chromatin, and no evidence of toxic change. Pelver-Hewitt anomaly in an Australian Shepherd, completely normal. These neutrophils function completely normally also. And we'll say that Pelver-Hewitt anomaly can present a major problem for automated analyzers. Okay, so toxic change, Dolly bodies, is the mildest form, and it's characterized by these blue inclusions that are associated with ribosome there, so that these cells are increasing their phagocytic capacity there. So Dolly bodies, blue. Cytoplasmic basophilia is the next moving up in severity. Cytoplasmic basophilia is second, and same cells, same images here. We've got ropey gray cytoplasm, which is very characteristic of that cytoplasmic basophilia there. And one way to actually differentiate from a monocyte, if you're questioning or uncertain there, is that ropiness to the cytoplasm. Now this is actually blood from a human, but it's a nice depiction of the cytoplasmic vacuolation. If you recall a couple of monocytes that I showed you earlier, it had a few discrete vacuoles. They were very small, pretty even in size. These vacuoles here, and these are the lysosomes, are the vacuoles forming these vacuoles. They're variably sized, they're big, they're clear, and they're numerous. They really fill the cell there. Human neutrophils do have orange granules normally associated with them, and this one actually has two cocci or paired cocci phagocytosed by that neutrophil. And then the most severe form of toxic change is called toxic granulation. It's characterized by red granules, similar to these here. So red granules, these are neutrophils there. Is this toxic change? And the question, if I told you this was a cat, well, think about this, toxic granulation. We just said it's the most severe form of toxic change. Well, where are the Dolly bodies? Where's the cytoplasmic basophilia, that ropey cytoplasm? There's no vacuoles either. This is actually blood from a Berman cat, and these are normal. They have red granules in their cytoplasm. So this toxic change not picked up by automated analyzers, not and certainly in a Berman cat. Just something to keep in your mind, especially the feline practitioner. Okay, normal lymphocytes, scant rim of basophilic cytoplasm. Sometimes it's characterized as denim blue, might have a little pale perinuclear zone there, which is the Golgi apparatus. Reactive lymphocytes, usually much larger, a little more open chromatin pattern, and frequently the cytoplasm will conform to the red cells around it. That's a classic feature of a reactive lymphocyte. So just show you some granular lymphocytes. If you immunophenotype these are most commonly cytotoxic T lymphocytes. If they're in a packet, it might be a natural killer cell instead. And then atypical lymphocytes, large cells, much bigger than the neutrophils, that open chromatin, immature chromatin pattern, kind of lacy or stippled, indistinct nucleolus there. So high suspicion because the population of lymphocytes are pretty monomorphic. Here, an immature, large, abundant cytoplasm that actually goes all the way around the nucleus. Be worried about either lymphocytic leukemia or leukemic phase of lymphoma, something along those lines. And just to show you a comparison, this is really about the same magnification here, how much bigger these are than that, than these small mature lymphocytes, normal lymphocytes. Again, automated analyzer will not pick this up. All right, moving on from white cells to platelets. So automated analyzer indicates thrombocytopenia. Difficult venipuncture may actually be due to platelet clumping, so you need to examine that feathered edge. We are at the extreme feathered edge here. This is what a massive clump of platelets look like. This is also a clump of platelets there. So most likely that thrombocytopenia from the automated analyzer is artifactual. It's a falsely low count there. And when you get these big platelet clumps, it's really hard to do a platelet estimate there and get an accurate one there. There is AI detection or deep learning that can detect these platelet clumps along the feathered edge. Think about causes of platelet clumping and aggregate formation. It's common in healthy cats, especially at the feathered edge, and then especially in a fractious cat with difficult venipuncture. Cats just have sticky platelets, and they like to do that at the feathered edge. Both under and overfilled EDTA tubes can lead to platelet clumping there. See it more commonly in cats than we do in dogs or horses. I don't recall seeing it in ruminants as effective EDTA, but I suspect it can occur. Inflammation may result in sticky platelets also, so keep that in mind. Hemolytic anemia, especially if there's an immune component to the platelets. And then iron deficiency anemia, frequently there's thrombocytosis, but those platelets may clump together. In an automated analyzer, you get a thrombocytopenia. Okay, platelet estimate from a smear. I'm just going to quickly go through these. So using a 100x objective, if you count 9 to 20 platelets, that's probably adequate. 18 to 40 for a 50x and 23 to 50 on a 40x lens. Again, the goal is to get an estimate, not an exact count. Is it adequate? Consider that for spontaneous bleeding, platelet counts less than 10,000 per microliter. So we're talking at 100x objective. You're looking at 2, maybe 3 platelets at the most for 100x field. Spontaneous bleeding does not occur until really below 10,000. May see retinal hemorrhages at 50,000. You can get an AI platelet estimate, which is much more accurate than what you or I can do. And it does it much more rapidly. So we're just going to count some platelets here. So this is digitally zoomed to 120x. So our field of view is actually smaller than what we would be looking at on a 100x lens. So it counted 9 platelets, and 9 to 20 was considered adequate. I think that's a platelet there, but I can't say for sure. And there may be one other platelet over here too. So in this patient, I would say it's adequate. Doesn't matter for clinical decision making. I've ruled out thrombocytopenia, and the exact count not real important to my decision making. Also consider whether the bone marrow is responding to a thrombocytopenia and look at platelet size. I tried to zoom this one as much as possible to show you the little tendrils coming off of these platelets, and we certainly have a variation in size there. And some of these platelets, macro platelets, are getting close to the size of the red cells. So in-house in-clinic analyzers may actually show an increased MPV in these. Emma, do I still have time?
Yeah, we have a few minutes.
Okay, I'm gonna move on. We're gonna jump past that. So this is really the crux of what I want to get across today, and that's we talked about this before. Blood smear evaluation in 5 minutes, and it won't take me 5 minutes to discuss this, but you can do a blood smear evaluation in 5 minutes and make your clinical decisions. Again, it requires a well-prepared blood smear with that feathered edge and the monolayer, which is going to be in this area here. Okay, and I'll just draw it on there for you. Once you get beyond this line here, it's really too thick. And really, when you're out in this area, it's too thin, and you can make every cell, every red blood cell, look like a spherocyte. So avoid that. So feathered edge at low mag, look for platelet clumps. Shouldn't take more than about 30 seconds to see those platelet clumps. And you should be able to see them if they're big platelet clumps. Really, you can see them at 10x, 20x, and go up to 40. If you have a 50x lens, fantastic. You can absolutely confirm those. Then from there, find the monolayer. For digital scan images that are using AI, white blood cell differential counts, the monolayer is automatically detected, and that's where the white blood cell differential and estimates are performed, also where the platelets are. If you're using conventional microscope, find the feathered edge, and then at 10x, if you just move 1.5 to 2 full fields into the body of the smear from that feathered edge, that should put you in the start of the monolayer. If the patient's anemic, you might have to go one more field, but you should be in that monolayer. That's really where you want to do all of your evaluations. Red blood cell evaluation, 90 seconds. Are there morphologic changes? Great. If you recognize them in the specific one, then you've narrowed your rule out list down. But even if you haven't, can't identify the specific one, there are cytology atlases or hematology atlases available online. You can do a comparison there. We're working on an AI evaluation of morphologic or detection of morphologic change and the specifics with that to help aid in that clinical decision making. Are there parasites present? RBC parasites? Are they intracellular or extracellular? There. And again, that really can be done in about 90 seconds, I think. White blood cell evaluation, you can do a real quick white blood cell estimate, and is there a leukopenia, normal leukocyte count, or leukocytosis? You don't have to be accurate, exact with that. An automated analyzer usually is going to give you a much better estimate than what you can do. What's the primary leukocyte type? Segmented neutrophils? Is it lymphocytes? Is it reactive lymphocytes, atypical lymphocytes? Is there inflammation? Are there immature granulocytes present? Left shift, toxic change? The goal, again, is not to get a perfect white blood cell differential, count 100 white blood cells. It's to guide your therapy, guide additional diagnostics, and help formulate a prognosis. And finally, a platelet estimate. Again, about 90 seconds on that if you want to do a platelet estimate. Typically, I'll drive around and look at 10 fields and just say, yeah, there's 9, there's 15 platelets there. It's adequate, they're increased or they're decreased with that. And that can be done in a few seconds there. And then are there large platelets there indicating if there truly is a thrombocytopenia, that the bone marrow is responding? Are there infectious agents in the platelets? Now that would require a little bit more time. Sometimes, especially anaplasma in dogs, that can be a tough one to find. But if you have digital images and AI there that has that capability, then that will help you further refine your time